factual statement of both the pros and the cons of screening is essential for a woman to make an informed decision whether to initiate regular mammography and at what point. Do we now have evidence that would support a woman's decision if she decides to begin screening mammography in her 40s? The best data we have is from 8 randomized clinical trials involving over 180,000 women, including the 5 most updated Swedish studies. Few trials have enough instances of death from breast cancer to achieve statistical significance in answering that question. But analyzed all together by a procedure called meta-analysis, there is now a 15% statistically significant reduction in mortality for screening beginning in the 40s. The meta-analysis included the 8 randomized clinical trials that were conducted over 30 years in the United States, Sweden, Canada, and Great Britain. What does this mean to an individual woman? In general, a woman in her 40s has a 1 in 66 chance of being diagnosed with breast cancer and a 1 in 190 chance of dying from breast cancer that develops in that decade. A 15% reduction would lower these odds of dying to about 1 in 220. This year, as we heard, over 30,000 women in their 40s would be diagnosed with breast cancer, and a 15% reduction in mortality would mean over 1,600 lives saved. Why would a woman choose not to have a mammogram? What are the limitations and downsides of mammography? The first relates to false positives and medical procedures involved in the follow-up of these false positives. If women were to receive yearly mammograms for 10 years, it is currently estimated that as many as 30% will have an apparent abnormality detected, and up to 1/4 of these will result in a biopsy or an invasive procedure. Only 1/4 of those for women in their 40s would prove to be cancer. In other words, most abnormal mammograms do not signify cancer. Beyond false positives, mammography may miss up to 25% of breast cancer in young women. What about the risk of radiation? This is a theoretical concern, but it is based largely on exposure to very high doses of radiation and in much younger women. While the risk of radiation should not be completely dismissed, there is no direct evidence that exposure of women in their 40s to the levels of radiation used in mammography causes breast cancer or poses any other health risk. The presidentially appointed National Cancer Advisory Board, which is the oversight and advisory board legally constituted to advise the National Cancer Institute, will and had planned to discuss the issues of screening mammography and the results of the conference, the results that were not just the consensus report, but very importantly, the stimulation and presentation of lots of new data on which we can all make decisions. Based upon those discussions, the NCI will move forward in terms of information, education, positions, and the research we need to do to address this question for women at all ages. We must provide information to every woman and her physician or caregiver to ensure that such information is accurate, is current, is balanced, and is user-friendly. Mammography has an important place in our current approach to breast cancer, but we do tend to overestimate its benefits. We must remember that 70% of breast cancer deaths in women over 50 will still occur, even with regular mammography. We must not lose sight of that we have to be relentless in our search for a cure. Women deserve to be active and educated participants in their own healthcare decisions, and we cannot produce certainty where it doesn't yet exist. Physicians and scientists must be active partners with consumers to use both the best evidence as well as the best judgment to help each woman reach a decision that's right for her. Based on current evidence, we must inform women that there are pros to screening mammography as well as limitations for initiating screening mammography in their 40s. We must be wholeheartedly committed to helping each woman weigh these pros and cons, as you said, as a critical part of her health care.
Dr. Klausner, in your statement, you say, quote, "It is my opinion that the draft report of the panel overly minimizes the benefits and overly emphasizes the risks for this population," close quote. Aren't you pretty flatly saying they're wrong?
I'm saying that the balance with which, the balance of the data and the evidence that they presented, the tone of the report, in my opinion, was not reflective of the balance of evidence we now have, largely because I thought it minimized the evidence that there is benefit, and it overemphasized certain risks, such as radiation risk, which, as I said, is, I think, a quite theoretical one.
Isn't that an elongated way of saying, again, that they're wrong?
No, I mean, I do think that there is a difference between sort of evidence and the verdict you reach, and we look at multiple pieces of evidence and we weigh them in order to then reach a conclusion. And I felt that the conclusion was very defensible, that women need to be informed to make a decision. But in order to be informed to make an informed and educated decision, we have to be very clear and not about whether there are pros, and I believe there are, and what are the limitations. And there are limitations, or else we can't expect women, with the support of their physicians, with the support of us, to be able to make that sort of informed decision.
Dr. Klausner, either I hear you saying for a third time that they're wrong, or I hear you saying something candidly which is unintelligible. The women in America in the age category of 40 to 49 need to know in unequivocal terms whether a mammogram would be helpful to them in detecting breast cancer. Right. Yes or no?
And as I said, I hope I've been trying to be very clear, and that is that the evidence is, as far as I can read, the evidence is that there is a statistically significant benefit in terms of reduction of mortality over long periods of time from initiating screening at some time in your 40s. I think I've been very clear with that. And as I said, I disagree with that aspect of the report of the panel.
I take that as a yes. The report issued by the consensus panel is denominated draft.
Yes.
Question in my mind, and I know that you're going to convene the National Cancer Advisory Board on February 25th and 26th, is why issue a draft report which has so many open questions? I think it may be worth just a minute because a lot of people will focus on this dialogue as to the import of what doctors say as they reach their patients' ears or they reach the ears of people who are concerned about the particular problem. And I referred in a very personal way to my own experience. Somebody looking at my MRI and a snap of the finger saying, weeks to live, an erroneous reading of the MRI, thankfully. And as Senator Harkin points out, the message has gone out to a lot of women, don't do it. Dr. Blumenthal testifies about a variety of factors of fear, concern of radiation. If there's any reason not to go to the doctor, let's not go. Let's not get the test. Concern as to what the test may show. This has received enormous publicity, and I don't know that you can ever put the genie back in the bottle. And my question to you is, why release a draft report which is not final and is not the ultimate word?
That's a very good question. Let me correct something. This is not an NCI report, nor an NCI panel, nor an NCI advisory body.
Well, didn't you appoint them?
No. No.
How did they come into existence?
So let me explain this. There is, I think for about 20 years, there's been an independent jury-type mechanism for consensus conferences at the NIH in order not to in any way be viewed as prejudicing the outcome of a discussion about mammography. I discussed this with Dr. Varmus, and we went to the office at the NIH that is separate from the NCI to ask them to convene this independent panel. And it's the panel's report, and that panel report will be useful to us as we then proceed.
So this is not NCI, not the National Cancer Institute, it's the National Institute of Health.
No, it is, the report actually is the report of this independent panel. It is convened by the Office of Medical Applications Research within the Office of Director of the NIH, and I was not involved with choosing the panel. I met the panel for the first time at the beginning of the meeting. And
well, the document says, in addition to draft, National Institute of Health Consensus Development Statement. Should I be asking Dr. Varmus this very good question?
I think, let me say, and we have been discussing the very good question about whether the process by which a draft report is released so quickly after a very complex and conference.
Well, who's responsible for releasing the draft report, which has all the indications of being a premature release?
This particular process is the current process of the NIH consensus process in the Office of Medical Applications Research, and based upon this experience, we are in fact discussing, and I have been discussing with the head of that office, with the person responsible for that, as well as Dr. Varmus.
Who's responsible for releasing the draft report?
It is, the process is set up by this Office of Medical Applications Research, and it is the report
Is there
of
a person there?
Yes, Dr. Harlan is the associate director that oversees this.
And is he responsible